Everybody, welcome to Compliance After Dark with Coffee Compliance and Chuckleheads. As always, I'm Sean Weiss, Jordan Johnson, and Eric Rubenstein. We're back in town, a little Thin Lizzy. I was hoping somebody was going to pick up on that, and sure enough, it was my brother from another mother, Eric Rubenstein, who kind of said, I'm liking that tribute to Thin Lizzy. So it's been a while, and I was wondering, how are we going to start the show? Are we going to start it with 5 minutes of abuse? Are we going to start it with 5 minutes of abuse for Jordan Johnson, or are we going to? Yeah, Eric wants to abuse him. Okay, well, say hello, guys.
What's up? Hope everybody's doing well. It is full-fledged summertime. It's hot here in the South, as Sean knows. Eric, I don't know what the temperature is where you are. If you're in Florida, then it's hot too, and we're all miserable. So
it is. I am in Florida. It's hot. I'm going to New Jersey in a couple of days where it's hot, and I was just in Europe for 12 days where it was not hot, but I did get sunburn. But looking at Jordan. Two things, because I got to get it. One, I did notice he's got a new picture on LinkedIn. You see that? And number two, you're red as an apple, my man. What is going on?
Listen. That I wasn't in the tractor with the cab on it. I was on the mower, and it got a little hot.
You fix that by getting somebody to mow your lawn for you.
You just put it on under your eyes, baby.
Yep. So, all right. Well, before people start dropping off and leaving the show because they want to hear something other than us beating up on Jordan for a little while, let's jump in and let's get serious, because there's a lot going on in the world of healthcare right now, whether it's operations, whether it's law enforcement. There's just so much going on. One of the first areas, why don't we go ahead and start with this? Jordan, I want to start with you tonight, if that's all right. We are still in a public health emergency for all intents and purposes, right? The federal government, irrespective of what the individual states have done, right? The federal government has not put an end to the public health emergency. And as a matter of fact, there's some reports saying that there's another spike in COVID, but unfortunately, well, we're going to leave politics out of it. As a result, what we have seen are constraints put onto operations. And one of the big ones that has hit is at Ohio Health. So can you kind of walk us through what's going on there and talk a little bit about the impact of the layoffs?
Sure. So I think this is a pretty big part. I mean, in the midst of the strain that we see, and unless you live under a rock, this is the worst time possible to go to a hospital, any hospital, due to staffing shortages and lack of supply chain disruption. Well, now the problem is these hospitals, they're already stretched. We all know that the only mechanism they have to control costs, 55% of their budget, 60% of their budget is salaries and wages. So in an already stretched and strained and bent scenario, Ohio Health has made the choice to lay off 600 people. Now, Ohio Health is not unique. It's just unique when you Google it, and it was such a big number. I think we're starting to see others that are starting to follow and smaller layoffs. And they laid off towards the upper end, not towards the clinical. And some people would say, well, usually it's the clinical people that get laid off. Well, the reason the clinical people didn't get laid off is they've already been cut. They're already as thin as they can be on the clinical end. So now it's trimming that admin end, the manager end, the director end. And this is a bad sign, because what will happen is, if we can come out of this PHE in a decent amount of time, like Sean talked about, if we get out of this, the correction period and the ramp up period, it's going to be very, very difficult. And these are not small hospitals, right? So then the other fear is if these small hospitals cave to the pressure, these rural hospitals, then they're going to dump their patient population onto these larger hospitals like Ohio Health, and that we're going to have difficulty. So I think it's important to watch the healthcare layoffs right now, because it's something that we need to pay attention to as it's happening across the country.
Yeah, I would agree with you. And no matter where you turn, we are hearing horror stories of hospitals, physician practices, laboratories being short staffed, being unable to keep up with current demand from the patient populations. Uh, I just don't know to what end it's going to lead us to. And, how many physician practices were forced to shut down during the pandemic and have not been able to rebound? How many small hospitals, especially those in the rural areas? And I know, Jordan, you and I get a lot of opportunities to talk about, concerns with what's going on in the rural healthcare community. And the fact that if somebody in government doesn't start to pay close attention to what's happening there, we're going to have patients that are going to have to travel hundreds of miles to be able to get any level of care. Forget about quality care, just to be able to get any level of care at all.
Now I see a huge deficit that's looming, and it'll be interesting of how they address this deficit. We saw the proposed rule, but in the final rule in the fall, how do they even address this through telehealth? And they can't just continue, and we talked about this, they can't just continue to give rights and privileges and scope of practices to advanced care practitioners. And what does that do to the current physician population and their reimbursement? So it really is a catch-22 and almost this forced downward spiral part of correction. And you just hope you come out on the other side able to still weather and push forward.
Yeah, I'll come back to you because, you're talking about the spiraling of healthcare, right? And, that means that we're talking about the financial spiral of these organizations, right? Not just operationally, but we're talking about the financial aspect of that as well, and what options physicians start to seek in these times of difficulty, right? You've got slow pay by insurance companies, you've got no pay, you've got changes of policies, you've got the take it or leave it mentality from some insurance companies that are pushing out their new fee schedule contracts for providers, and they're saying, take it or leave it. You don't want it, you're off the panel. And then the physicians are scrambling, trying to figure out what they do from there. But I want to stay on the topic of the pandemic for just a moment, Eric, and I want to switch over to you, because it just seems like people never cease to amaze us with the level of intelligence that they demonstrate when it comes to how they create fraud. So, sticking with the theme of COVID, what's going on in the world of COVID vaccination cards?
Yeah, so it's an amazing thing, right? Because now that we're in a quandary, so we've still got a public health emergency according to the government, but yet there's no mandates to show vaccination or proof of vaccination, basically anywhere you go anymore. I just came back from 12 days in Europe. Vaccination isn't even discussed anymore. No one's around talking about it. You didn't need to show proof of vaccination to travel. You didn't need to show proof of vaccination to go anywhere. I didn't see anybody wearing a mask. On some of the flights I did, some of the trains I took I did, but generally not. But what really is happening is now all of the prosecutions for the COVID card fraud, the vaccination card fraud, is now starting to tick up. You're starting to see a lot of these people now being convicted or pleading guilty. And it got me thinking that because there's been this sort of scattering of prosecutions, what are people being charged with? Because one of the issues that has been a kind of prevalent thing, and we were just talking about this, and we talk about this all the time, is there's the difference between a logo and an insignia when it comes to the government, and the reproducing or the use of a logo is legal and lawful. The reproduction or the use of an insignia is not. And if you look at your vaccination card, it isn't an insignia because it's missing things that appear on an insignia in the government. And there's an actual violation of federal statute for reproducing the insignia, but there's no violation for the logo, which has been kind of the problem along the way. So I did a very quick search on the internet this afternoon and wanted to see, like, what are people being charged with? So before we even talk about being charged with, there's some state statutes that people could be charged with. So in New York State, 2 nurses were charged for making $1.5 million for doling out bogus vaccination cards. But really what they got hit with was they were actually reporting to the New York State vaccine website through the State Department of Health. They were reporting the fake jabs and then giving out the cards. So it was kind of this twofold thing. And then interestingly enough, I found that in the state of Florida, there was a Democrat back in October of 2021 who proposed. Now, listen, I'm in Florida right now, so I know it's the land of some weirdness, but and there's a little bit of a denial of COVID in the state of Florida, but a Democratic member of the state legislature proposed a felony violation for producing and possessing fake COVID cards. So, there's been this little bit of this back and forth in the states, but federally, just looking at some of the stuff federally, people that have been prosecuted for the fake cards, everything from theft of government funds, which I don't quite understand that one, but theft of government funds. That was a nurse out of Detroit. So I'm reading some notes I've got. A nurse at a VA hospital, theft of government funds. She was selling them on Facebook Marketplace and using Facebook Messenger to communicate. Like, you've got to be kidding me when you see that. There was another one. That was out of Detroit. There was another one that was very similar. That one was in Baltimore, and that was a guy who was he got charged with mail fraud and obstruction of justice. He was actually putting out on social media, "I'm going to be rich." He was out there selling those cards. He got mail fraud and obstruction of justice for that one. He made like $30,000. But you see these all over. There was someone in Williamsport got charged for making false cards.
Yeah.
And that was for false use of the insignia for the CDC. So I'm guessing that those cards, when they were being reproduced, they were being reproduced with an insignia versus the logo. I did find a civil case. This one was an interesting one. This one was a civil case out of Ohio where they actually were charged with misuse of the insignia under Title 42. And so the thing, I got a list of about 8 or 10 of them. And what really was just amazing to me was there was no consistency under which to charge these people with. I mean, look, I think now, since the mandates are kind of gone and people getting the vaccines are really, it's less mandate than it is more, through voluntarily being done, that these prosecutions, whatever's in the hopper is going to be in the hopper, because no one needs to prove that they've been vaccinated anymore for work or travel or anything like that. So I think whatever the prosecutions are for that is going to just kind of, those are going to go by the wayside. But the other piece of this puzzle, and we'll pause for this one, is the HRSA money, and the fact that the HRSA money has stopped for testing and for treatment and for vaccination. It's just run out of money and it's gone. So I think the next wave of prosecutions that we're going to see are really going to be on the HRSA part. I'm doing a ton of work. I know you guys are, but I'm doing a ton of work with overpayment issues with HRSA on COVID-related services on E&M. One of the biggest complexities with this is what should providers have been paid for E&Ms? And I think, and we should probably have an entirely separate Chucklehead conversation about doing audits on E&Ms and identifying what the proper overpayment amount is. It's nearly impossible because you don't get paid.
It is.
You don't get paid the fee schedule. And I don't want to go off too much on a tangent because I'm dealing with it now, but I think the next wave of
A few moments later.
Whoa, what was that?
Who knows?
I think Sean's apparently got something that he's playing with over there, another like device.
It's not me.
All right. Well, I think so. The next wave of well, you could say it's not you, but you're in charge of a lot of things, so you know. Anyway, I think the next wave of stuff we're going to see are going to be overpayment letters coming in from HRSA. I'm working with a lab right now that is a traditional lab that got involved with doing COVID testing. They got a letter from HRSA asking for 318 records. It's I don't know where they even got that number because this lab was doing thousands of tests a week, a month, whatever it was. 318 records were requested. This is months ago. We still don't have a response from HRSA as to what the results are. HRSA actually put a stop to payments pending the outcome of the audit. We don't know how they came up with 318 claims. That's going to be the next wave.
I want to pick up on that, right? So I want to kind of shift over from the HRSA, but I want to talk about audits for just a minute, right? And HCC audits, risk audits, whatever you want to refer to them as, okay? I refer to them as a pain in the butt, okay? Because they 99.9% have zero impact on the physician practice or the entity for which these records are being requested from. It doesn't impact your reimbursement. It doesn't impact your operations. This is basically for these Medicare Advantage plans to be able to demonstrate to mothership that they are processing claims of a higher level of complexity. So we need a bump in how much you guys are paying us. Let me tell you something about this, okay? First off, all of these Medicare Advantage plans, all of these other groups, okay, they're all getting bumps. Who's not getting a bump? The physicians. They're getting a bump, but it's a bump on the head. And let me tell you something. The audit that came in, this was the most comical thing to me. Okay. Let me ask you both, and let me ask our listeners, viewers, okay? Is there any difference if I say to you HCC audit versus risk audit? No. The answer is no.
Yeah, there shouldn't be. Risk adjustment and HCC is, those are interchangeable. They're interchangeable terms.
That's right. They're synonymous to each other. I had an individual from an insurance company send me back a letter, send me back an email, because they wanted 257 medical records from my client. And I said, absolutely not. And they request this on a quarterly basis. Okay. They request it on a quarterly basis where they want an egregious number of charts. And I finally stepped in because they asked me to. And I said, look, here's the deal. We have had zero response from y'all in the past year. Yet every quarter you've asked for somewhere between 100 and 200. Now you're asking for 257, 258 charts. It's not going to happen. We're going to cooperate with you. We want to provide you with the information that y'all need. But folks, this is an HCC audit. They called it a risk adjustment audit. And the guy from the insurance company responds back to me with, let me be clear, this is not an HCC audit. So I had to go on to CMS's website and I had to literally cut and paste the official definition of an HCC audit, which states an HCC audit is a risk adjustment audit.
Yeah.
And, I told him, look, here's the deal, y'all. We'll give you 100 charts per year because you don't need anything more than that. We'll give you 100 charts per year. We'll give you 25 per quarter, or we'll do it biannually and we'll give you 50 twice a year. No problem. But 100 is enough. And if you want to argue with me, then I'm going to take it to the Centers for Medicare and Medicaid Services, and I'm going to take it to the Secretary of HHS, and I'm going to file a dispute because this is absolutely nonsense.
So one thing
They
I'll
are
tell you,
asking us to
Sean,
take our staff time. They are asking us to spend our resources, and we're getting lumped on the head. If you look at and Jordan was kind enough to come on the Compliance Guy podcast today. We did a great episode that's about 45 minutes. It's going to air on Thursday, talking all about this kind of nonsense. And Jordan gives some tremendous guidance in that. And I can't wait for y'all to hear it. But go ahead, Eric. You were going to say something. I'm sorry.
One thing I was going to say is, so we do over here at Advise, we do a lot of these HCC and risk adjustment reviews. We have, a lot of people know we have Brian Boyce works for us. And Brian Boyce is the author of the textbook that the AAPC uses for their CRC training. And he's doing a lot of the work on the payer side. We're seeing an uptick on the payer side of these audits. They're really becoming commonplace, and they're coming kind of fast and furious. And I think a lot of it is in part because of the DOJ interest in these. And so a lot of these plans want to be on the right side, right? Because DOJ is suing, right? So there's a key TAM.
Well, they're going after them.
Right? So DOJ, there's a key TAM that was filed against Kaiser. And I think DOJ's got a case. Is it Anthem, or there's another one that's out there? But there's two big ones, right? So a lot of these plans are now thinking like, whoa, we got to fix our house and, get these going. And that's, I think, a little bit is part of that. And I think, part of it is what people don't realize is that the fraud committed in the Medicare Advantage world, it doesn't affect anything today. It affects you a year from now or 2 years from now when those risk scores are recalculated. So I think part of what you're seeing on these larger audits is the result of that happening. We're seeing left and right the plans that we do SIU and payment integrity work for on that side of the house. They're getting, these contracts are coming in left and right where they're asking us to do a lot more of these reviews.
So my thought, I guess my problem with that is, no, you're already short-staffed. To Sean's point, the amount of resources and money that this is taking from an already short-staffed practice to produce, there's no difference to what Sean said between 75 and 100 and 500. Somebody needs to be held accountable for that, and they can't just force these practices. I mean, that's the difference in some of these practices staying open or closed. Are they spending time with the two people they have, seeing patients and bringing patients in? Or are they spending that time coming up with these charts for no reason?
And I apologize. I started smiling when you mentioned Brian Boyce, because I was going to say something like, "Isn't that the ice skater?" And then I remembered that was Brian Botano or somebody like that, wasn't it? I don't know. It's been so long since we've been together that I feel like I have so much pent up frustration that I just got to have my release.
It's very possible, right? It is. It's very possible.
And Pam, if you can find a citation, Pam, while we're on here today, that would be fantastic. I'd love to be able to share it. The ADR request that I know from, just in my head, is Chapter 3 of the Medicare Program Integrity Manual. I think it's 3.2.3.4. But you may want to go ahead and take a look in that section to see if you can find the limitations on the request for HCC requests. All right.
Off the top of your head. I think it's page 27 of the Program Integrity Manual, section 3.2.1.7, subchapter A.
All right.
Open parens.
Right. So listen, I'll share with you. So, because I'm so proud of this.
You're like the minister. You're like the minister of Medicare. So we, as you know, we just came off of a huge win on behalf of 4 physicians. It was United States v. the Pain Centers of America. And one of the physicians had been in jail, or federal detention, let me use the right term, for about 3.5 years, Dr. Bothra. And through the masterful work of the defense counsel in the healthcare fraud
portion of this, led by Ron Chapman II of Chapman Law Firm. I mean, he is the Fred Astaire of, defense counsel litigation work. I've never seen somebody move as gracefully as this guy does around a courtroom. It's just something to. I wish we had CCTV in there, man, so people could actually watch what's transpiring. But it was crazy because I never had an opportunity to really do trial prep, because it wasn't until a week before that I was told, hey, we need you to come here to Detroit and we need you to testify. Now, if anybody hasn't read this case yet, this was 4 physicians who were indicted under a grand jury for 54 counts of violation of the Substance Control Act, as well as for violation of the healthcare fraud statute. Long story short, jury of 12, and Ron starts off by saying to me, Sean, is there a chapter from Medicare that you can help us to go to that talks about how an audit is conducted? And sure enough, I said, sure. Chapter 3, section 3.2.3.4, additional documentation requests. And it was kind of like the jury went, what? And it was funny to watch the prosecutor start to scramble and start writing little notes on stickies to each other. Long story short, to your point, I wound up citing about 6 different chapters of the Program Integrity Manual in specific sections. And it's unbelievable, the information that if you'll just, if you're suffering from constipation or from insomnia and you need relief, pick up the Medicare Program Integrity Manual and just start reading the different chapters. It's guaranteed to work for both. Promise. All right.
The sad part about this,
I want to go back.
John, I actually found, so believe it or not, there is a guy online known as the Medicare Minister.
Oh, God. Only you, Eric. I swear.
He's only got 3 followers.
The Minister of Medicare. Wow, that's pretty outstanding. All right, before anybody tunes us out, I want to go to another serious issue, right? So, urgent care centers. Okay, no, there's not a huge amount of information out on urgent care centers, but folks, they are huge targets right now. And if you're an urgent care administrator, if you work in an urgent care center, I don't know how else to say this, but stop screwing around, because it's no longer a matter of if you get audited, it's simply a matter of when. And if you are taking advantage of billing for high levels of service, or you're billing for services in addition to other services that should be bundled together, they're going to get you, and they're going to get you hard. Eric, let me come back to you, and then Jordan, I want to go back to you on something with PE.
Yeah, so yesterday on your podcast, you talked a lot about Modifier 25 on your roundtable, and we talk about Modifier 25 incessantly, and the fact that it's a huge target in the Medicare world. We already know that the commercial payers are targeting Modifier 25 yet again by making providers provide their documentation on E&Ms with Modifier 25 separately, which is going to trigger some delays in payment and things of that sort. And we know that Modifier 25 is a really misused code modifier, because modifiers are descriptors. They provide a greater description of what the CPT code is. They provide that granularity. It could be something like left, right, bilateral. It could be, separately identifiable, like the Modifier 25 is. And it's going to become an issue. In the world, when COVID hit, urgent care centers filled a void that was very, very important, right? It allowed for continuity of care to exist when emergency rooms were shut down. And urgent care docs were really putting themselves at great peril because emergency rooms and hospitals were essentially shut down. We know that there was a huge decline in emergency department visits and admissions and the like, because people who were sick just said, I'm toughing it out. And, we don't even know like to what extent, but urgent care centers filled this role that was very important, which is why, in part, I believe CMS never came out with a rule that said you can't bill an E&M when you do a COVID test. In fact, to the opposite, it was if you show up at an urgent care center under, CMS was saying you can bill for E&Ms when appropriate. But, what we're seeing is now, as a result of that, now the new target are the urgent care centers, because they became that fail-safe, for lack of a better term. I'm working with 2 urgent care centers right now where, they potentially have some substantial overpayments out there from, modifier 25 issues, from upcoding issues, just because to a large extent, there was this deluge of people that needed care. And it's like, we just need to get these people treated. And so, you're essentially a one-armed man in a waving contest. You're just trying to keep up with everything that's going on. That was a good one, right? You're just trying to keep up with, with things. And that's going to be it. I mean, the bigger problem is that billing companies were just giving really bad advice. I mean, really bad advice. And
I agree. And I agree. And our LinkedIn user friend, you're right. The CS modifier is another modifier that has been absolutely abused, because, simply put, if you use the CS modifier, it will get your claims paid at 100%. This has become such an abused modifier. That's why, it's being looked at very closely. Thanks for bringing this one up.
I mean, with all the data, right? It's low hanging fruit for them to just come back and take back. And I think a lot of people, it was good while it was good. But to our point, just because you get paid today doesn't mean you keep it tomorrow. And that's the point we're at now. They're going to come back, and now they're collecting that back. And it's not hard for them to figure out where the issues are.
And I'm sorry, it was Christine Hall. For some reason, it popped up on my studio as LinkedIn user, but when I actually looked closer, it's Christine Hall. So I apologize about that, my friend. Look, I want to go to you, Jordan, because I think this is an excellent opportunity for us to discuss the involvement of private equity in healthcare. And I am seeing PE show up in dentistry. I'm seeing PE show up in urgent care centers, in ambulatory surgery centers. And some people are going to say, but Sean, they've always been there. Sure, they've always been there, but not to the degree that they are right now. And it is creating a lot of noise. It's creating a lot of chaos. And I think one of the most important things, Jordan, before I turn it over to you, is if you're a physician who has left a hospital to go into private practice, you did that because you wanted autonomy. You did that because you wanted to practice medicine the way that you believe is best for your patient population. If you enter into agreements with mezzanine financing, venture capital, private equity, whatever it is, if you give them a percentage of the operations of your organization, you are once again in the same boat that you were in when you were an employed physician of a hospital. So let me pause there. Jordan, talk to the chaos, the noise, what's going on in healthcare with PE right now.
So no, I think it's coming off the heels of these strap practices post COVID, right? And so these firms had a lot of money. They had money set to the side, and all of a sudden they saw it as a very opportunistic to say, hey, almost like, hey, you're down on your luck, for with interest, I'll help you out. And that's pretty much the way this is playing out. And they're showing up everywhere. I mean, dentistry, infusion centers. But to your point, the physicians oftentimes, and nothing against physicians, I work with them all the time. Sean and I talked about this morning. They did not go to business school degree. get a business school, or business degree. That's not what they did. They got a medical degree. So the minute they put themselves into making complex business decisions, it oftentimes ends up being a bad decision. And so that's where they're at. And I think a lot of them, they're going to answer to shareholders. Once you bow to private equity and VC, where it may solve an issue, you are going to lose some of the autonomy and the reasons that you got into that's the practice the way you want to, and not to be told, because then the answer is to the shareholders first, and then to you and the patients are really second. So it's there's a lot of strings attached, and you need to know what the strings are, because these agreements, they're lengthy, they're complex, they're confusing, and they're written that way on purpose. And you can't just, it's not a volumetric draw, meaning you sign with private equity and all of a sudden you're going to see 700 more patients tomorrow. It's not the way it works.
Yeah. And one of the things I will tell you, and I'm not trying to bash on PE in any way, shape, or form. I promise you I'm not. But I think people need to have realistic expectations, and they need to have an understanding of how it really works. I've been involved now in a number of acquisitions by PE firms of physician group practices, of surgery centers, where we've been asked to perform the due diligence. And when you get into an initial discussion or even subsequent discussions with some of the folks on the PE team, and you hear how they want to change the billing of services, how they want you to do certain things, you have to wind up finding a way to explain to them, you can't do that. The way that things worked in this other industry that you just came from, that's not the way that it works in the healthcare industry. We are the most rigid, we are the most stringent, and we have the most statutes, laws, rules, regulations of any other industry that I can think of outside of nuclear. So
yeah, a lot of people
Yeah,
see
go
it
ahead.
as an easy way to make money, right? Healthcare, because there is a lot of money in healthcare. I think it's also important. Nobody talks about the ugly side, right? 91% of health tech businesses fail within the first 3 years. That's just a fact. And so
Right.
PE and VC, remember, they're not only investing in you, they're investing in a diversification for their portfolio. So they may have 20 investments. They know and assume the risk that probably 15 are going to fail, 5 are going to hit. Those 5 that hit offset the 15 that fail. It's a nasty gamble, but people play the game every day. And I think right now you just need to be cognizant and know and be aware of what's going on. I mean, money may help your practice. Money in large scale is not going to fix healthcare. Okay. Warren Buffett tried it. All the big groups at Haven. You really have to understand healthcare. And Sean, I talked about that this morning. Eric, you understand healthcare operationally. When you just have a finance degree or it looks good on a spreadsheet, that's the problem. You really have to understand the fundamentals of healthcare. And that's why having a subject matter expert, having somebody that understands the historical, that knows the laws, that knows the context, those are the people that are going to be able to support you, not the person that took a weekend course and now declares themselves an expert, or the Medicare minister, as Eric found. And I'm hoping that he has a Medicare mistress to go along. But anyway, that's neither here nor there.
All right. So Eric, I want to go to something that is so significant in our industry, specifically for prescribers of opioids. And it's the SCOTUS decision that recently was handed down, that again our good friend Ron Chapman played a significant role in, with filing his amicus briefs and engaging with the Supreme Court. But talk about what the SCOTUS ruling means now, because I have some thoughts on it as well, but I want to get yours initially on this, please.
Yeah. So the Supreme Court came out with a ruling a few weeks ago that essentially says that in order to prosecute a healthcare provider under the Controlled Substance Act for a pill mill, we'll call that, sort of generically, that provider must knowingly be misprescribing those opioids for it to be a crime. You need to be able to prove that the scripts were an aberrancy. And so that is going to present a challenge now, because the previous sort of MO was this provider is writing a prescription for you to get 3,000 pills or whatever that may be. In the absence of a medical record, so that's where the issue is going to be. How well is the provider documenting the medical issue on this? And then does this now call into question? So this became sort of my collateral thought to past couple of days, really, is when you're talking about drugs, like, for example, Subsys and fentanyl, and there's a thing called REMS and turf REMS, which are part of, it's the agreement about on label, right? Like, so the fentanyl, Subsys is the fentanyl spray, and the SCOTUS decision came about as the result of two doctors who had been convicted of prescribing Subsys through the INSYS fraud cases that came about with regard to kickbacks and the like. And so it's going to be interesting from a law enforcement perspective. The issue has been that prescribers have been prescribing a drug like Subsys off label and fabricating their turf REMS documents or things like that. But what's going to be interesting is that if a provider is saying, look, I think that this is a drug that is going to be beneficial to you, and they're documenting the record to show it, you've now got this argument from a state licensing perspective, right? Doctors have plenary licenses, which means that they can, kind of prescribe what they want to prescribe if they think that there's a medical efficacy, for it. I mean, that's kind of a dumbed down version of it. But, the issue is now going to be a doctor that runs a pill mill that on its face may be a pill mill because of the volume of prescriptions that they're writing, but has a well-documented medical record that supports the medical necessity that says, I gave this patient, they were on Motrin. We did a step-up therapy, right? It didn't work. We moved to 800 Motrin. It didn't work. We went to, a C5, like tramadol. It didn't work. I moved them up, and then boom, we're where we are today. It's going to present a challenge for being able to prosecute. And so the interesting part for me is we had the Appalachian region, the opioid task force in the Appalachian region, which has the highest incidences of drug overdose and use and all of those statistics that are out there. The successes they had, they then created the New England version of it to attack the same problem in the New England area. And it was based upon the successes that they had. The question is going to be, are the prosecutions in the New England task force going to be stymied by SCOTUS's decision regarding this issue?
Yep. So let me jump in if you don't mind for just a second on this, because you took it right to the point where I was hoping you were going to go with this. Absolutely. So for all of our viewers, our listeners, there's something out there that is called prosecutorial discretion. Okay. Now, what that basically means is in all of these cases that were previously brought, it wasn't that prosecutors have to be held accountable for bringing these. Their hands were tied based on statutes, based on laws. So what the SCOTUS opinion now does, what the ruling now does, is it puts it back onto the prosecutor's shoulders directly. And they now have to use prosecutorial discretion, because to Eric's point, they have to be able to show that the prescribing habits of the physician were knowingly bad or knowingly problematic. It's no longer a matter of, well, we saw this many and we think you're on the face of things a pill mill. What all of these prosecutions have led to, and Eric, you experienced this with Jean Marie's mom, right? When, she had her little intervention that she had. They didn't want to give her any pain medication. It was Tylenol. So I will tell you, I have looked at thousands of medical records with our team. And when I say thousands of medical records, I'm talking about surgical charts where you look at the postoperative plan and there is no mention, even when you look at the discharge summaries, there is no mention of the patient being sent home with any opioids. Nothing for breakthrough pain. It's Tylenol, Motrin, Advil as needed. And the reason why that's happened is why, Eric? Because of all of these freaking prosecutions that never should have taken place for honest prescribers. Yeah, I know somebody out there is going to say, but Sean, think about all these people that there's a bad element everywhere. 95 to 98% of all prescribers are good, honest, legitimate, hardworking clinicians wanting to make sure that their patients are not in pain, that they're taken care of, and that if they need something, they have access to it. This is why you sign patient contracts when you enter into, a pain management clinic. This is why you have a urinalysis. This is why you have a definitive test if, the doctor feels like you're not being honest. I mean, I get it. There's frequent flyers out there, but folks, this SCOTUS is not only good for prescribers, it's good for the patient community because patients who have legitimate pain no longer have to worry about going to the doctor and the doctor saying, I can't write you that script. I mean, I have doctors that wrote a script for 3 hydrocodones for a patient that had a massive surgical procedure, and they sent them home with 3. If you need more than 3, call our practice, and that's all they were giving. One surgeon said the max that I can actually prescribe is 10. So, to me, this SCOTUS ruling is huge.
Yeah, it's gonna be interesting to see how this pans out with prosecutions. What is going to become that threshold? I think for a lot of these prosecutions, the problem is when a provider signs with their patient the turf REMS, like we're talking about fentanyl spray, and they sign the turf REMS agreement. And the problem is that when you sign that agreement, the agreement is to prescribe this to you for breakthrough cancer pain, and it's got to be a documented record of breakthrough cancer pain. So the problem is that when a doctor signs that turf REMS agreement and then is prescribing it for something other than what the turf REMS says, that's where you have this that's where the issue is going to be. You're going to have a doctor who's going to say, I really think that this subsys fentanyl spray is going to be the right thing for you, but they're not really well documenting the medical record to say, I'm going to this because of that. And then I'm going to give you this fentanyl spray, and we're going to sign this turf REMS agreement, which says, I'm agreeing that I'm writing this prescription because you're having breakthrough cancer pain, because that's what the on-label. That's where we're going to have these problems with not prosecutions, but that's where providers are going to run into problems. Providers are going to run into problems when they're doing something that is a circumvention, right? So, if, in a search warrant or a record review, and you see a turf REMS agreement, and there's no indication in the patient's record that they have cancer. There's no indication. And what there is an indication is that you're giving them that fentanyl spray for some non-cancer pain, but you've got a document that says, I'm agreeing that I'm only going to give it to you for cancer. I mean, and that document becomes your intent document.
I mean, it's a fear thing with the providers, right? So a lot of the providers, exactly that. If they're truly doing the right thing and document the right way, we all know nothing to worry about. But the level of fear in all of this for opioids is so high that they're going to use, they're going to use Ultran, they're going to use Tylenol, they're going to use gabapentin, which right now is not a scheduled drug. It may move that way, but they're going to use those things before they even think about writing a scheduled drug. They just don't even want to med it.
Yeah, no, that's a great point. That's a fair point. All right. The last thing that I want to talk about is a very, very straightforward, simple issue. And Eric, Jordan, I know you guys have your thoughts on this as well. Folks, listen to me, please. I'm going to readjust myself in the seat for this one here. Look, here's the thing.
Strap in. Strap in.
When you receive a letter from an insurance company asking you for the production of medical records, don't sit on it until the day before it's due and then reach out to somebody like myself or Eric or Jordan expecting us to wave a wand and automatically get you an extension. Folks, they give you deadlines, they give you drop dead dates for a reason. Okay? When you receive an additional documentation request, whether it's from an SIU, which automatically you should take extremely seriously, because again, it's a special investigative unit. They're looking for fraud or abuse. If you get one from the RACs, if you get one from a UPIC, if you get one from the MAC, if you get one from, doesn't matter. If you get a letter requesting additional documentation, you need to either, if you're going to handle it internally yourself, you got to respond to it within 5 business days of receiving it, especially if you're going to request an extension. Now, I have some latitude because
Did we lose Sean because he was so excited about this?
He got so excited, man. Sean,
I think his internet. You know, we were.
Hey,
whoa,
he's back.
We thought you were so.
Whoa, that was really odd.
You were so excited about your
back.
latitude. You were so excited about your latitude. You went longitudinal.
He was choppy.
Yeah, you're not kidding. I'm so sorry. I don't know what happened. We must be having a storm or something here. But all I was going to say is, look, people like Eric and myself, we have some latitude when it comes to reaching out to an insurance company and saying, look, you know, we just got retained. You know, we just got retained yesterday, or we just got retained 2 days ago. We need the extension for us to be able to do what it is that we need to do to effectively respond. So, anyways, that's where I was going to leave it. Eric, Jordan, any final thoughts on that?
My only words of wisdom are like you said, is don't wait. I don't understand. And then we have people that want to take the cheaper way out. You know, the cost to process data is almost nothing because it's data at mass scale. It's a program. And so we'll have a lot of people that say, no, I don't want to look at all of my data so then I can see patterns and trends. I just want to look at 10 charts and I have 10,000 patients. That bothers me because it's like literally we can process all of your data for you to see, but you just want to look at 10 charts, which we know is not a representative sample. And so, again, don't delay, don't wait, and don't always look for the easy way out, especially right now with so much low-hanging fruit. It is a game for these people to come and recollect this money. It's just like shooting fish in a barrel for them.
Yep, absolutely. All right, that's going to bring us to the end of this episode of Coffee Compliance and Chuckleheads, Compliance After Dark. It's been such a great opportunity to hang out with Jordan and Eric again. I've missed you guys. I know that we have had a conversation just yesterday where we have decided that for us, it's going to be best that we're going to put the show out 2 times per month. And we are in the process of working on a schedule again with everything that we all have going on. It gets a little bit difficult for us to all align sometimes, but we are committed to getting the show out twice a month. And from that standpoint, I'm going to sign off by again saying to everybody, thank y'all so much for tuning in, logging on, and hanging out with us. for this episode. Eric, Jordan, I'll leave it to y'all.
Yeah, Jordan's got to he's got to go because he's got to put on some lotion. He's got to put on some lotion.
Y'all
All right. Before the abuse gets worse. All right,
they
guys.
say it gets
Thank
worse.
y'all so much. We'll see you in a couple of weeks.
They say it gets worse before it gets better.
Words of wisdom from Eric Rubenstein. Y'all take care. We're ending the stream.